Welcome, welcome everybody. We'll get started shortly.
Good afternoon. This is Kelly Sheets. I'm with Department for Medicaid Services. I will be hosting your meeting today as Erin is on maternity leave. So, I'm still admitting folks through the waiting room, Dr. Richardson. So we might want to give it a couple of minutes. Right now, I only have 2 members on. That's you and Wanda Figueroa Peralta.
My system's not letting me start video, so I'm just gonna log out and log back in so I can make sure I'm on video. I'll be right back.
Okay, thank you.
Okay. Well, it is about 1, so we can jump right in. Leslie, if Leslie's on, we would love for you to do a little welcome.
I am on. How are you on this beautiful day in here in Kentucky? It's beautiful. I would just say to everybody who knows or doesn't know me, my name is Leslie Hoffman. I'm Deputy Commissioner for Department of Medicaid Services, and I proudly serve as one of Medicaid's racial health equity champions. And on behalf of Medicaid, we'd like to welcome each and every one of you here today for the Cabinet's March Disparity and Equity TAC. So the Medicaid updates will actually be later in the agenda. I'll turn it over back to you.
It looks like we have 4 members on now. I have you, Dr. Richardson, Wanda Peralta, Jordan Burke, and Patricia Bautista Rivera. If I'm missing anyone, please speak up as we do not have a quorum.
And what is quorum for us? 5?
Quorum is 6. You have to have more than 50%. Yeah.
Well, we'll hold on the approval of minutes, and we'll look at quorum again after we have some discussion.
Okay, I can let you know if more members jump on and we do get quorum as we go along. I'll make sure to break in and let you know.
Okay, well, we'll just jump right into the agenda. The agenda, again, is just all of the prior minutes, or the previous minutes, the notes and ideas and things to follow up on. I don't know if it'd be better to take the agenda off of share screen so we see each other better. Would that be helpful?
I typically share the agenda, but I don't have to. It's completely up to the pleasure of the TAC.
Let's take it down for a while. We can always pull it back up. And then let's see. Let me do a view so we can. Okay, it's a little easier to see faces. So, okay. So first, I'll just put it as the first thing in old business, which is the next chair. This is my last meeting chairing. It's been fantastic, so I highly recommend it. Do we have any volunteers at this point to be the chair for the next 2 meetings? We'll bring that back a little bit later. Let me make sure that's on chair. Okay, well, Jordan, Patricia, who I'm not sure who else is on. I can't tell on my screen who's here, who's on the TAC, but anyway, speak now or speak at any point during the meeting if you want to chair. Okay, so the next section is just the review of goals and strategies that have come up over the last discussion. So the first is the immunization fee schedule updates. As we mentioned, that children who are on Medicaid, if they go to a provider that does not have the Vaccine for Children's program, they're mostly not receiving vaccines. They're told to go elsewhere because the Medicaid fee schedule for the immunizations themselves don't match cost for providers. They're off by just a couple years, not way off. So I'm not sure who has the update on that.
This is Justin Derringer. I'm the acting director for the Division of Healthcare Policy. And I've got a couple of people on the line today or with us today that oversee the
Your Gatorade's in there.
Somebody's Gatorade's in there. But that oversee the physician's fee schedule. And so we can look at that and I'll have them kind of talk about what we did to some of the codes and if we had any updates on those codes within the last couple of years on the fee schedule.
I didn't hear that last, and it may have my audio. Do that again. I think Justin. Oh, there.
Oh, yeah, I'm either cutting in or out, or somebody's cutting in or out. I'm not sure, but I've got a couple of employees on that deal with the fee schedule that contains those vaccine codes, and Jeannie Jolly and Tom Young, and I'll let one of them talk about how we've updated those within the past within this past couple of years on that fee schedule.
Okay, I can give you a little bit of information on that. I have been the one updating the codes on the physician fee schedule and the preventive health fee schedule. And normally when one is updated, they're both done at the same time. And we would make changes in those when normally it's the health department contacts us saying that the cost, the reimbursement is not covering the cost of that drug. So we normally ask them just to furnish the cost and we change it. I know when we added a lot of the these codes that we used to only cover for children, and we have to now cover for adults as far as vaccines. So in the past, we were just covering for the, providing the vaccine. They were usually getting the vaccines through, for free. So any code that the health department tells us that they're wanting to provide for adults, we go in and add the average wholesale cost for those for adults.
So yeah, this TAC brought up, I think in our first meeting, we're not the health department, but we're also providers, and the fees for those vaccines do not match cost for pediatric offices. That's why they're not providing them.
I know some of the vaccines are federally reimbursable, and some of them aren't. We've increasingly asked because there's two different things. You have the actual vaccine, which is usually on the through the pharmacy side, and then you have the administration fee, which is on our fee schedule, which we reimburse for regardless. So with the Vaccine for Children's program, we just had that fee for reimbursing. Erica Davis is on here. Erica, do you know if we do anything through EPSDT, or if a child wants to? I know we've talked about this vaccine issue before, but is there anything that we have that that would speak to that, do you think?
Not for the EPSDT program, but the CDC does release the cost for vaccines for the private sector. So that may be something that we could look at to just match what is on that CDC price list with what we have on our fee schedule and see what those differences are.
Yeah, we can definitely take a look at that. And again, you know, it's on a kind of the actual vaccines kind of on a different fee schedule. We do that through our pharmacy part, but we can definitely get with that group and see if we can adjust those payment amounts if they need to be adjusted. One of the things that we'll look at is what Erica just said. Another thing we like to look at is we like to see what other states are paying also surrounding Kentucky. So we like to look at, you know, see what Tennessee, Ohio, West Virginia, and Illinois and Indiana are paying. And that's usually the way we do a lot of our codes when we have any kind of upgrade or increase in payment for those codes. So we can definitely take a look at that and do a little bit of research and see where we're at if that's an issue for sure.
Yeah, and thanks, Justin. So we have been talking about this since the very first meeting. So I would like to kind of get maybe more of a strategic action plan so that we can maybe wrap this up in the next couple of months.
Sure.
So the issue has been that it is primarily the pharmacy costs that we've been talking about, the cost for the Pneumovax, the cost for the Prevnar, the cost for the actual medication just hasn't kept up from the last update. These costs often update yearly. And we feel like it's an important equity issue for children on Medicaid that cannot get their vaccine at their pediatrician's office because the pediatrician isn't paid enough for the medication. I think the keeping up the admin fee is also very important, but usually that's not the sticking point with pediatric offices because those vaccines are so expensive that if the cost is even off by 10%, that could be $50, you know? So we spoke last time also about, even though it may look like, let's see, how do I say this? It may look like on some public list that it's about the right payment for that medication. You have to look at actually what people are paying. You know, those costs are sometimes averaged out and can be lower if you're looking at a general reference sheet versus what the actual cost is. And so I suggested last time that when you come up with an updated fee schedule, that we run that through some high Medicaid practices that are using purchase stock, not vaccine for children, to make sure that the changes that we make have the equity impact that we want them to make.
Yeah, we can take a look at that. One of the things to remember is that a lot of times costs, especially on the pharmacy side, will change throughout the year. And in addition to that, different providers get their medication from different providers. So you may have a pediatrician that's going through one source and their cost is $20 per vial, and another pediatrician is going through another source, their cost $75 per vial. And so we have to make sure we look at all of that and take all that into account. But yeah, I think we've done some preliminary work by looking at some of those things and how they fit. And I think we did have an increase from last year, putting those things in place. If we're not keeping up with the cost still, then we definitely need to, kind of try to figure out a new method. But, we do have to keep all those things in effect and look at those things because we have to be good stewards and make sure that to be honest, a lot of times when we reached out, a lot of people said they just didn't want to fool with it. It wasn't a money maker for them. So they, a lot of the pediatricians were just kind of pushing that off. And that's something that we have to look at too. How can we, other than just, increasing fees so that they make money doing it, what other things can we do to maybe help them to include that as part of their service?
Right. And I'm just talking about the people that have vaccine in the refrigerator that they're giving to other children in the building, but they're not giving to kids with Medicaid. Those are the only practices I'm concerned about. I think it's a whole, like you said, it's a whole different issue if people just aren't giving vaccines. That's another another approach to that. But if we can just keep kids in there getting the vaccine linked with their visit, we feel like that's a really important equity issue. Do we need to talk offline about this too, or do you just want to give us a report back, maybe an update before the next meeting, or what do you
Yeah,
think?
let me give you an update 1st of April and kind of let you know what we found out, what we're looking at, and I'll send it to not Erin, I think she's out, but I'll send it to Kelly. I'm sorry, Kelly. I'll send it to I'll send it to Kelly and have her send it to the TAC members. If that's agreeable.
Sounds good.
Awesome.
Can I
Thank
ask
you.
a question? What if the problem with the providers, if they're getting the vaccine through Vaccine for Children, they're getting that
No,
for free?
Oh, I'm sorry. This is the providers that do not do vaccines for children. The providers that only have purchase stock vaccine, but they have Medicaid patients as well.
Well,
So
why would they not be getting the drugs through Vaccine for Children program?
So, yeah, that's a very complex question. Vaccines for Children can be a very labor-intensive program. You know, it's highly monitored and regulated, which is a good thing, but it takes a lot of staff time to administer a Vaccines for Children program. If only 10% of your patients are Medicaid, 20% are Medicaid, you're not going to pay that much to make sure that you have can meet the Vaccines for Children guidelines. So it's the administrative burden, which I know we've talked about in many settings. I mean, it's a great program, but it's not without its challenges. And if you're a low volume Vaccine for Children provider, people may not feel like it's worth the time investment for the practice. All right, well, thank you for that. Anything else on immunization? So we'll get an update around the 1st of April from Justin through Kelly. All right, the next thing we brought up last time was transportation access. Jordan talked a lot about challenges in rural Kentucky. I talked about in urban setting about access really for specialty care, even just to get the primary care office, but certainly really complicated care trying to get people transportation. We talked about the challenges historically and currently with federated. We asked if this was something that we should take to the MAC, and we were told no, that it's more right now, you all would prefer us to have the conversation within this group. So what would be, how can we have a productive conversation about this that is helpful for Medicaid from obviously with a health equity lens, because this disproportionately impacts people that have less transportation. So who from Medicaid wants to give us an update on that?
Justin, do you have anything to add? I know we've been working on a lot of, in general, transportation access right now, specifically to behavioral crisis, medical crisis, our mobile crisis, which we can talk to you about that later. We've also, Justin's group, I think, completed a SPA to remove the requirement that, or to remove the factor that if there's a car or vehicle in the home, they've removed that, right, Justin, and your SPA has been approved. So that was that
was a big barrier. So one of the things that we had looked at for non-emergency transportation to services were you would have someone who was for instance, that was living with someone else. You know, we find that situation a lot, whether it be a relative or non-relative. And the way the old regulation was written, the way the old state plan amendment was written, they took that household into account, much like you would in a you know, a family support case or something like that, where you looked at the whole household. So it really disparaged families who are really down on their luck, who didn't have a place to live of their own, by moving in with other family members or friends for a little while, because then the people that were taking them in were kind of deemed responsible for their transportation. So after looking at that a little bit, we made a change to eliminate that requirement. And so now, instead of it being a vehicle in the household, so before, if you had a vehicle in the household at all, say somebody that's on a Medicaid eligible member, who's on Medicaid and has a lot of physical conditions, and they need to go to the doctor quite a bit, and they can't drive. Moves in with say their mother and father, and the mother and the father have vehicles, then they're not eligible for that transportation. So we changed that to now it has to be, the vehicle has to be in that individual's name. So if you are a Medicaid member and you have a vehicle registered in your name, then you're not eligible. It doesn't matter who you're living with. It's just the fact of, do you have a vehicle in your name? And there's also a couple caveats to that. So say you have a vehicle and the transmission goes out, you don't have enough money to fix it, you still can't get your appointments. All we need is a mechanic's note, and then you're eligible again. Even if you have a vehicle registered in your name, if we have a mechanic's note saying that that vehicle is non-running, then you're eligible again to receive that transportation service. And the third thing is a physician's note. If you are driving a vehicle, or if you have a vehicle in your name and somebody deems that, whether it's because of seizures or vision or whatever the issue may be, that you're incapable of driving that vehicle, we have a physician's note stating that you're eligible for that again as well. So we think that that change in particular will help open up a lot of different avenues and open up that transportation service to a lot of individuals who were not allowed to take advantage of that before.
That's great. Yeah, that's an issue that we find that comes up quite a bit. Can we get a copy, since the SPA's approved, can you share a copy of the SPA?
Yeah, we can get that to you. Absolutely.
Great. So that's great. Then I think, I don't know, Jordan, if you want to talk about, it still comes down to reliability of federated, and how do you all hold accountable a contractor that you contract with? How do you get appropriate feedback to know that it doesn't work great? Jordan, you want to chime in?
Yeah, I mean, that's a tough one. I guess just through patience, really. Talking with them about if, with these changes, if it's more accessible. Obviously, I mean, for children, obviously none of them own a car. So does that mean that, like, irregardless of their parents, does that mean that they're also, does this work for them as far as like this transportation thing? Are they automatically included, or how does that work with their parents?
So that specific question that you just had to bring up is the only one thing that is still not kind of set in stone. The regulation is ready to be filed and gone through, but that is the one thing that we're still kind of waiting on a decision about. So the way it's written right this second, it leaves it kind of open in the waiver, so we can go either way. But right this second, I can't tell you whether or not that their parents aren't allowed, that if that knocks them out, if their parents have a vehicle or not. If you'll give me about a week, I can tell you.
Okay.
Well, I can tell you what, it's an administrative regulation, so it has to go through the process.
Yeah.
But that's a good question. That's something that still hasn't been fully decided, but yeah.
Yeah, that was my main question through hearing it.
And I can't really tell you a whole lot more because it's a regulation that hasn't been filed yet. We haven't went through the promulgation process, and so there's still a ton of layers to go before that's actually set in stone. But everything else is kind of laid out in waivers, so that is kind of set. That's the one thing that was kind of left ambiguous in the waiver that we have some autonomy on in the reg, and so that language hasn't actually been. We're still kind of waiting on that.
it sounds like it'll definitely increase the number of people that can access it. As far
Absolutely.
as actually, like, how many, when you look at like utilization of that service, like, is there a lot of people that are able, like, is there a lot of drivers that are just kind of waiting for a patient or taking them to an appointment, or is it kind of at capacity? Or do you think by like increasing the number of people that will be able to access it, that you're going to get like bottlenecks on the actual number of drivers and stuff that you have for these people?
Yeah, I mean, I think the way the system's set up, we have a vendor, Kentucky Department for Transportation actually manages those different companies that provide that transportation. And so, they base it on kind of previous data. And so, but they know what we've done. And so they've increased the number of their contractors accordingly. And so it won't, maybe one of those things where it may be kind of bottlenecked for a little while, just depending, but it usually really doesn't work out that way. Sometimes it can. It just depends on how quickly word gets out that those people are now eligible, and how quickly people take advantage of the system. If it steadily grows like it normally would, where people find out, through one way or another, through their local DCBS offices when they go in, find out through friends, through family, through various other avenues and resources, and it kind of grows on that steady incline, then that lends to no bottlenecks. They're constantly adding vendors, and everything seems to work out really smooth. But if everybody kind of finds out about it at once, which is always a possibility, then there could definitely be some, a few delays or bottlenecks in the process. Yeah, but that's with anything that we do or implement. I mean, we don't really know what's gonna work out like that and what's not going to work out like that. And because the way it's set up, they can't pay because I think they pay the vendors when they, just for kind of signing on. So they can't pay, too many of those people without having the people to transport. So yeah, but it's a quick process. I mean, it's not like it's going to be bottlenecked for months and months.
Yeah.
And
So,
hopefully
I mean,
it won't happen. Like, hopefully it'll be a steady increase, and they'll just continue to add as it grows, and it'll be smooth. That's our hope. And they're ready. I
Yeah.
mean, they know what's coming. So
I mean, again, it's a good thing that they'll have more access and stuff. So, like, I mean, how are you guys going about, not just like through word of mouth from, each other, but like, how are we letting people know that this is now like a service that they do have access to, that they previously, didn't because of those restrictions?
So it's kind of a multi-head approach. So once the regulation's finalized, we have all the vendors that will be reaching out to some of the different groups that they work with and deal with. We'll send out a provider letter to different providers. So when they go into their local health department, their local pediatrician, their physician, that they'll have some information there. We'll have information online that talks about that, and then we'll reach out through our DCBS office. Also, we found that's a huge key to the community, is our local DCBS offices, because they have so much communication with the client, on a weekly and definitely on a monthly basis, that they communicate that with them as well.
Cool.
And then let me ask about pickup. So I know that's one thing I hear a lot from families, is they get dropped off at the hospital for their x-ray or whatever, but then they can't get back home.
Well,
it's supposed to cover both ways, right?
Yeah, it is. It's supposed to be both ways. So I haven't necessarily, I mean, we get lots of complaints. We look into those complaints. There is a formal process that we look at. I haven't heard that that's been a huge issue. I'm not sure. I don't really understand why that would happen so much. But we can definitely something we can look into to see how many instances were reported, how many we had, because that shouldn't be happening. I mean, if a vendor's in the area, I haven't heard that they're ultra busy to where people have to, wait long amounts of times. I think that happens every once in a while if somebody's in a rural setting, or if they're in concentrated areas in Jefferson County. I think those things have happened before. Even in Fayette County, you get that sometimes. But I mean, I wouldn't think that that would be something that happens a ton. You do hear about 20-30 minute waiting times quite a bit, but I mean, that's just kind of part of the process because vendors, sometimes they're picking up other people in between and those type things. So, but that's kind of, I haven't heard that as being an overarching issue, but we can definitely check into it.
Anything else, Jordan? I know you had told, the stories about those issues, trying to get kids to UK for specialty care and not being able to get transportation and
Yeah,
anything else.
it's similar, right? I mean, I can get appointments, but it's on both ends, right? It's both it being available and actually being utilized. So it's also taking advantage of that thing that is accessible. So that's also the problem I ran into. Please use it.
All right, thank you. Anything else on transportation for right now? So we'll get a copy of the SPA, get follow up on the question about the children and the assignment of a car or to the home. Anybody else? All right, the next thing on the agenda is the community health workers, because on the last meeting there was a comment that the SPA had been submitted for feedback from CMS. So we're excited to hear any updates on that.
I don't specifically have an update. I do know that it had an effective date of July of 2023. Does anybody know? Can anybody fill in the gaps for us?
I mean, the SPA was submitted.
But we haven't followed. We don't have any additional questions or anything that we still need to follow up on. Is that what you're asking, Dr. Richardson, if there's any follow-up since we submitted?
Well, when we talked last time, it had been submitted only for comments. It hadn't been submitted for approval.
It hasn't been submitted to CMS. Yes.
Yes.
And what time frame do you expect for them to approve or not approve?
Kelly, can you answer that since Aaron's not on?
Well, let me look it up real quick and see if I can find out if it's on the clock. Give me just a second.
Okay, you're fine.
Okay. And since it's been formally submitted, can we see it yet, or is it still confidential?
I believe it's still confidential. Leslie, correct me if I'm wrong.
Let's see. That one has not been approved, right? Let's not share it just yet. I can ask about that. I actually was not involved with that one. That's why I have limited information. I'm sorry.
Okay, it was submitted on February 7th, officially submitted to CMS on February 7th. The end of the 90-day clock is May 8th. So hopefully it will be approved by then.
All right. Does that help, Dr. Richardson? So if it's on a 90-day clock, then we should hear back on or before the 8th of May. Okay. And if we have anything in between, we'll bring that back. And I'm sorry that I wasn't sure exactly where we were in the process.
Great. Okay, so that'll be soon. All right, subspecialty access is another topic that came up about there being disproportionate access between people who have commercial insurance and people who have Medicaid for many specialists in adults and children. And we felt like that was an important equity thing to have a conversation about. So is that how in the past has Medicaid looked at that? Can we look at it with fresh eyes and think about different approaches now that we have this TAC to look at it from an equity lens, with an equity lens?
I'm gonna ask everybody again, did anybody from our group have a follow-up for the subspecialty access?
I can discuss, this is Angie Parker with Medicaid. I can discuss it at a very high level. We get, as far as network adequacy, we do get reports each month, I think it's each month, from the MCOs on where their providers are. And if they are, obviously we've had this discussion where it's challenging for certain areas of the state and, excuse me, for certain specialties and sometimes even primary care or dental. And we do get several reports submitted to us that are reviewed by certain personnel that can see whether or not their network is adequate. Now, MCOs may also identify that, well, they know that they're not adequate and they will ask for exceptions, and they have to supply that information of why they need an exception. So we occasionally do see those types of reports as well. I think we know we have this in Medicaid. I know we have this in general throughout the state in certain areas. If you're wanting to know, do we know of one specific specialty? I know dental is always kind of comes to the top as far as access to those specialty types. I don't think really it's that much different for other specialties than commercial for Medicaid. Now, you may have some providers who don't accept Medicaid members of a certain age or in those types of instances.
Right. So I think the conversation was, we know as clinicians that this is true, right? We know that if an adult in Louisville needs to see a rheumatologist and they have Medicaid, it may be never, maybe 9 months, maybe 12 months. But if you have commercial insurance, you can see somebody in a week. And so we know as providers that there are discrepancies in access. And we know that there are network adequacy reports from the MCOs, and they don't match, right? And so I think we have an opportunity in this committee, in this discussion, is how do we look at that differently than we've looked at it in the past as a state, and say, no, like really, what are the issues and what can we do to break down some of those conditions that exist, that we know exist, but don't always show up in the data because it's just one of those things. But we definitely know that there's discrepancies in child health as well as adult health in getting subspecialty care based on whether or not you have Medicaid or commercial insurance. I don't think that's the question. I think the question is, how do we as a TAC help you as Medicaid? Because, that's kind of our role, right? To drill down and to, bring to light like that. Anybody? I mean, I think these are the hard questions, right?
Yes, they are the hard questions. I mean, when you look at it as a whole, to your point, and whether or not they can see a sick child within 24 hours or a preventive visit within a month, which is what their access standards are to be. And, there's a lot of ways to review that through complaints or grievances or not just looking at a network adequacy report that we get from the MCOs, mm-hmm. But we can't work on anecdotal information. Mm-hmm. So, right. If there are issues that arise with somebody getting into seeing a provider for whatever reason, that's something we could look at, because we also have, that you're probably familiar with, if a person if they miss an appointment. So if they miss an appointment report, a provider can go in there and put into Kentucky Health Net that Angie Parker did not show up for her appointment at 2:00 on March 1st, didn't call, didn't give us a reason or anything. And we get monthly reports looking at that. And we provide that information to the MCO so that potentially they could reach out to the member to say, hey, do you have a transportation issue? What's going on? You missed your Angie, you missed your appointment with Dr. Richardson like 5 times. So there are those types of things going on. But as far as the access, people not even being able to get in to somebody, how do we track those? Instead of having, well, we hear this or we know this, but that's something that we do a survey, the MCOs do a survey, they call and act like a secret shopper and say, can I get an appointment for my child at, they have a fever, and to see whether or not they can get in at, within the specific time frames. Sometimes with those reports, and if a provider's falling out of that, of course, it's just a sample size too. It's not the entire network. And if that, if they're falling out of that, if they call every time they call this doctor's office to do a secret shopper and they can't get an appointment, then, they are to educate the provider on that, or to find out what's the deal, why, you're supposed to be able to, you're contracted to provide services to our Medicaid population. So, how do we address that? That's a very good question on how to get in to see somebody. If somebody has, I don't know, something you all could probably be better student in identifying, but they need to be seen sooner than 6 months from now. Do you get on the phone to the provider and say, this doesn't work? I need this.
Yeah, that's what we do, which we don't have time to do, but yes. That's
exactly. And I understand that. So it's a problem. And then again, and I speak from personal experience, some people don't, they just say, okay, they just leave it there. 6 months, I'll wait, instead of being an advocate for themselves, because they don't know how to do that.
And sometimes it doesn't matter. It doesn't matter how hard the patient advocates. I have a patient that was seen in the ER with a thermal injury to their cornea. This is a very serious injury.
Yes.
They were told to see the ophthalmologist within 1 week. They called the ophthalmology office and they said it'll be 2 months. We called the ophthalmology office. They said that'll be 2 months or 3 months. And so I had to call the ophthalmologist. I get to get the ophthalmologist out of a room, right?
Mm-hmm.
So, and I know that's anecdotal, but it's constant. And so I think it behooves us, of the people in power, right? You all pay the bills and we write the referrals. So how do we, and how do other states look more seriously at this issue? Because it's not new, but it doesn't mean it always has to be this way either. Does anybody else have?
I think we are looking at it seriously. I mean, it is, and I appreciate, it is definitely, and for the Medicaid population as a whole, probably. But I think was what sometimes people run into, like you just had to call that physician out of the office. Office staff are trained to say, this is what it is. This is what I can do. I can't do anything more than that. This is it. So in order for, they would have to go to a supervisor or maybe the doctor to say, okay, we need to get this patient in sooner. They're not usually given the latitude to work somebody in unless a doctor already has their schedule. And I know I'm preaching to the choir here, I'm sorry, but I already had it set up where they can work people in. But
right. Yeah. So how can we help you all as a TAC?
I'm open to your all's thoughts and suggestions. I think we are very much so.
And I, this is Justin again. I just wanted to kind of say that this isn't a issue unique to Medicaid recipients. If I run out of some medicine I'm on and I call to get a refill of that medicine and I need to go into my primary care physician, it's usually about a 3 to 4 week wait for me. And if I'm out of that medicine, which usually I don't know until I'm out, and I say, well, I need this medicine for, 3 to, and tough.
Right. I'm just talking, that is true. You are absolutely right.
But not just in that situation, but for every situation. So when we look at all of our different provider types, that's a complaint we hear a lot, so when we did some research and it's not just primary care physicians. It's not just different specialists. It's everybody as a group. I mean, we're having that issue with a dentist. We're having that issue, and then when we look and we reach out to some of the MCOs, and they're saying we're not just seeing this with our Medicaid recipients. We're seeing this with our private too. Everybody's having these longer wait times, and it just seems like maybe there is a lack of or a reduction in clinicians, maybe. Maybe there aren't as many clinicians per the population as there once were.
Yes, I think then that makes it even more complicated. You're exactly right. And I'm really just talking about the situations where we know, I'm telling you, this is true. I think, yes, it's anecdotal, but we call to get these appointments, and they have different scheduling criteria for Medicaid patients. They have fewer slots for Medicaid patients than they do commercially insured patients. This is not new. Of course, it's worse because of the issues. And it's true. It happens in my family. I call for my daughter for an appointment for the neurologist. I can get in a week. And I call for my Medicaid patient, and it's 4 months. So I just want to reiterate that it is all of the things that you are saying. It's true. It's worse than it's ever been, probably. But there, historically and presently, there's lack of access for Medicaid members compared to commercial. And so we can keep thinking about it. It's been this way for a long, long time. So that's why I'm sort of like, we can just keep letting it go the way it's always been, because it's too hard to fix, which may be where we end up because it's a tough problem. But I think we do need to at least agree that it happens. It really does.
Oh yeah, I mean, I'm not. Yes, I totally agree. I know it happens. It is happening. And I think Justin's hit that, and you're asking us how could we help solve this as providers. How do we get those providers' offices who say, I have certain criteria that I only see 10 Medicaid patients per week, so I've met my limit. How do we, do we penalize those providers? Is the expectation to pay more? I mean, is that the solution?
What do the contracts say between the provider and the MCOs? I mean, there's got to be language in there about, access.
And this is Stuart Owen from WellCare. Dr. Richardson, thank you for bringing that up. And so, all the MCOs, we actually do have teams that weekly identify care gaps, look at very detailed, sophisticated reports, but there are some, two things. I mean, there are some provider types that are just, there's a shortage in Kentucky, like pediatric psychiatrists, rheumatology that you mentioned, also eating disorders. But I guess just, maybe as far as a helpful thing, I mean, we have to find a member care. If there's nobody in network, we got to do whatever it takes. And I guess just one step is just contact the MCO or ask the member to contact the MCO, because if they call our customer services, then we're on it. We're working on it. I know that's, I guess an extra burden for you, but for the provider. But that's one step anyway, is just ask the member to contact the MCO customer services, and we'll work on it.
And what would they be able to do you think, your team? What are some of the successes you all have seen?
So good question. We've got to find care. So if that means out of network, we go out of network, and we will search wherever we can go. And in some cases, like with eating disorder, we actually go out of state to find a provider, but anywhere in network. And so we will offer, and another thing is just frankly, some providers don't want to participate in Medicaid for whatever reason. And so we will offer, it's called a single case agreement. We got this situation, this member needs this care. We've got to do whatever it takes to get you on board, to sign you up, to see them. And so that's absolutely one thing that all of us do. And just try to say, okay, just one time at least, see this member. So that's one thing we can do. But we've got to be aware, it starts with the member or somebody alerting us to the problem. Like I said, we all track the reports, but specific cases like that, if they call us, that's immediately we're on the job trying to find a provider.
So Angie, is there, so I know there's there's that phone number, I forgot I don't know if it's an ombudsman line or what is that phone number that people can call and make complaints or make comments that we've talked about in this meeting before?
Is it the CHFS listens?
Yes, that one.
I've got, I did a report. I've got a report from Erin, who's not here today, but I've got her report. I can share that with you, but didn't see anything.
Is that a phone number we should tell people to call about this issue so that you all get more specifics? Or
I think
how can you get information?
The CHFS listens is an email box, right, Angie?
It is, yes. Sorry, this is Kelly. It is.
So is there, when families come to us and say, why do I have to wait 6 months for this? Can we also have them contact you all so that you have these specific examples? Would that be helpful? Or do you feel like you have enough information?
Well, I think it's something that, as Stuart mentioned, if they have an MCO, to call the MCO. If they are a fee-for-service member, they should call the customer service or member service number that is on the back of their card and let them know. So they can,
and not so much to get care, but to get you all the data that you need to look into it differently. How
that would that's a very good question. I mean, as far as if they're contacting the MCO, that could be something that potentially if they have it set up through their grievances process, it would be already identified that way, identified through which we do get reports on member and provider grievances that the MCOs receive.
would that come through your grievances? Anybody from any of the MCOs? Or would you just work on it and not submit it as a grievance?
That would be captured as a grievance. That's a grievable. Pretty much anything is a grievable. Any complaint or problem you have is a grievance. So, but that would be captured on it.
All right, so we have some workarounds. Having families call the MCO, and if they call the MCO, it will be listed as a grievance, so it will go up to Medicaid. Angie, what other, if you had a magic wand and you could wave it, what would you need? What kind of information would you all need to make decisions, like to decide, even if you couldn't pay more, but to say, okay, well, really what the problem is, it's a money problem, or really, just to define the problem better?
My magic wand.
Yeah, your magic wand.
You're putting me on the spot, Dr. Richardson. I mean, it's, I don't think that I can give you a specific answer to that question because it's so large. Because there's too many variables, I think, to kind of really assign my wish through a magic wand. We had
not even to fix it, but a magic wand to identify the problem.
Well, it's like I said, I think, we do have the grievances report that we can go back and the MCOs can look at as well to see if they're getting those types of information. And if they are, how are they addressing it with the provider? Not knowing the specific reason per se that the providers are, just setting up their policy to only see so many Medicaid, how we address that. If that is an issue, it needs to be addressed with the provider, unless the contract says that's all, we are going to be doing with, that's all we're going to be setting up. It's a Medicaid is a third of the state is on Medicaid. And so we kind of look at, so is a third Medicare and another third commercial. So as I've heard the commissioner say many times, we are helping fuel the economy. And, you know, maybe Medicaid doesn't pay as much as commercial, but I worked in commercial insurance and I know they don't pay a lot either. So I wish, what would I wish for? That
what would you wish, like that we interviewed all the practices that are not taking enough Medicaid, or like, is that how we find the answers, to talk to the specialist and say, okay, tell us what's going on, help us to understand?
Well, I mean, yes, survey. I mean, I do know that there are surveys that are done that could be done if providers will answer them. We do have challenges with, and I know they have challenges, they being the MCOs have challenges with getting responses on surveys. You know, I think anecdotally, we've heard that, you know, we don't pay enough, is probably the primary reason.
And I note also, there's a higher no-show rate with Medicaid members. That's a big complaint. Providers schedule appointments and even multiple times they won't show, and there's no consequences with Medicaid members. They're protected fairly. And I know that was when you said surveys, I remembered I think Public Health did a survey for dentists about a year ago or so, and it was you know, exactly those issues. Why are you not? And it was everybody trying to capture everybody. Why are you not in the Medicaid program? Why'd you leave the Medicaid program? And I know no shows was part of it, but I do recall that the response rate was pretty low. I don't know, maybe 15% or something, which by survey standards actually wasn't that bad. But I mean, that's, you know, that's a good idea. But I do remember for certain, you know, lower reimbursement and high no-show rate. So you're scheduling appointments, booking appointments, and then they don't show.
The improving the non-emergent medical transportation would improve the no-show rate.
Yes.
I think we could hypothesize that would be. It would make its sense. I mean, I can tell you that, you know, at the last meeting when we were talking about transportation being a big issue, you know, when we talked about that, the MCOs, they offer value add services of transportation to doctors' offices or bus passes and that sort of thing. So we are looking more into those value add services, particularly in certain parts of the state, to see how or if they're even being utilized. But I don't have all that information yet on the transportation issues. We know that's huge. So once and hopefully when the regulation is filed and we get that we can see an improvement in that area as well.
Okay, so takeaways from this conversation. I'm not sure. Do we have any takeaways from this or any next steps?
That it's a work in progress.
This is Leslie too. We always would welcome, like if the TAC wants to ask, like if the TAC wants to bring things to us for us to research or look at too. It's so huge right now, and we're at the beginning stages, right? It's so big. If you can just give us specifics that we could start taking a look at, I think most of this team on here would be willing to start doing that.
I just had it. You can go ahead.
No, go ahead.
So we know that like for certain subspecialties, patients go out of state, right? Like it's impossible to get in within a reasonable time. So like pediatric gastroenterology, I mean, sometimes when I call UK, they're like, just call Cincy, because the timeline, and I'm sure there's other adult specialties and things like that. Obviously child psych. I mean, I don't even know that I can get an appointment anywhere in the state for one. How much money goes out of the state? I mean, just for those types of services. I mean, like, obviously paying everyone more is not like an option typically, right? But for, I don't know, select services or things like that, whether it's somehow enticing, there's provider shortages, how much money is going out versus how much, to entice those types of subspecialists to be in this state. I mean, I don't know the numbers obviously, but if just from our small clinic, there's a handful of patients, I'm sure statewide that adds up to a pretty sizable number over the course of a year. So I would just be interested in knowing how much money is going to healthcare services that are offered in the state but aren't accessible and have to be accessed elsewhere.
That's a great one. Yeah, I sent everybody to Cincinnati too from Louisville for GI.
I
And
experienced
I
that.
guess, I mean, go ahead.
No, I was just going to say when I worked in commercial insurance, that was a big issue. Pediatrics in general, really, and in the state of Kentucky. And I always had to look at either Vanderbilt or Cincinnati.
And I'd mentioned too, coming out of COVID, I've spoken with a lot of folks related to GI specialty right now, especially liver specialty GI. There are absolutely, definitely a workforce shortage right now. And I think it was November, I tried to schedule an appointment for a family member and we got to May the 25th from November. So I finally, after I've called around for months and months, I've got it to April the 21st. So it's definitely a shortage, and people coming that this is just an example of many things. Eating disorders is another big deal coming out of COVID, but folks who had GI and or liver issues, kidney issues, who were not necessarily getting out during the COVID time, and now it's compiled and everybody has there's an enhanced need right now for some specific specialties, if that makes sense.
So that's Jordan brought up a great question as a research question. I mean, when you said like specific questions, is that specific like, let's define the discrepancy in Louisville on adult rheumatology? Is that those types of questions?
Sorry, based on what he said, I was writing that down. I don't know if I would know how many from his personal facility or where he's working that did not receive services that could have in Kentucky and went to Cincinnati. I don't know that I would be able to tell that.
You mean in general, like across the state?
Yeah, I wasn't meaning like our just practice, but I'm sure that anytime a patient, and I could be wrong, but I'm sure anytime a Medicaid patient from Kentucky accesses services outside Kentucky, I'm sure there has to be some kind of conversation across state lines. I mean, I could be wrong, but.
So, Angie, I'm going to ask you if Ken or if the MCOs are online, Stuart, are you able to tell if a Medicaid member went from Kentucky to Cincinnati because the service wasn't available?
I don't know about that. I do know that we contract with the border providers, and I'd say all the MCOs do, like Cincinnati, Vandy, because you got members that are near the border. It's actually just more convenient for them. So we do, a lot of the border providers we already contract with. Their in network, even though they're out of state, because it's convenient for the member. We have place of service. I don't know. I don't think that the data would show couldn't get it in network, went out, other than, like we could look at single case agreements, obviously.
Yeah, that's what I had mentioned earlier. That's the only thing that I could think of, but that's usually because the service is not available the ones that I've been on here lately, the single case agreements for eating disorders have been because
Right.
it's not available in Kentucky.
That's a perfect example.
Well, as far as MCOs, my assumption is that all MCOs require prior authorization for any service that's out of network. So there should be a way to get that information via a report of out of network providers authorized. And you could drill down, you know, I don't know all of your systems, but that's some that we could look at. And then we may already be getting a report like that to go in and looking to see.
Dr. Richardson, we'll take a look at that and see if we can come up with either a way to narrow that down or to see if we might have a current report that we could take a look at with Angie. Is that okay?
And yeah, and that's just, you know, we don't know what kind of, we're not data people, so I don't personally know what kind of questions that are good research questions for you all to elucidate these underlying access to specialty care. So do you all have any suggestions of things that we could ask for? Like, you know, like I mentioned, do you want specifics like why can't we get an adult with Medicaid into a rheumatologist in Louisville? Like, is that the type of questions, or do you mean like digging into the data questions like Jordan mentioned, or what would be helpful to elucidate this?
I think to get started, we might be able to try to see if we can narrow down the data. On this particular, like overall, we'll see if what we can come up with on existing reports versus if the MCOs might be able to narrow something down. And I'm not sure that I was just using Jordan's area as an example and then thinking holistically for Kentucky. I don't know if we can drill down to that, but we can try. We can see what we've got.
Or maybe we can look at single case agreements and where they are and what they're for.
Yeah, we could ask for that at the same time if we don't have that somewhere, single case agreements, and what they're for.
I'd never heard of those, so that's
the ones that I've worked on have been specifically for children that have recently come out of COVID and needing help with eating disorders, and we don't have. I've heard that we've got one that's trying to get going, maybe in the Louisville area, but we really don't have anything right now.
Yeah. Oh no, I just had never heard of we have many children who need access to eating disorders. We didn't know that there was a thing called a single care agreement or single case agreement. So that's good to know.
It's basically a one scenario arrangement contract. You know, it happens with emergencies too, though. I just thought it would skew it. You know, the Medicaid members, I don't know, they're in Iowa, they're in a car accident, and so they get treated there at a hospital, and so that's actually happens as well. And so we've got to, you know, have to do a single case agreement, one time scenario, sign a deal with you. So that, you know, that would kind of skew it, but.
And I'm actually, you're right, because the ones I work on are all for private duty nursing, and they're with fee-for-service patients, you know, so it would only be the fee-for-service part. So I think the individual MCOs have their own probably list of single case agreements that they work on.
Okay, it is a little bit after 2. So what I would propose as the as chair, if there are no objections, for us to move to save the rest of the items in the goals and strategies review and move on to the racial equity core team updates, minority health report, and division of quality and population health updates, so that we can get some make sure we have time to get those updates from Medicaid. Are there any objections from anybody on the TAC?
Before you move, Dr. Richardson, we talk about the review of fee scheduling for vaccine providers, but this is for the ones that don't offer the vaccines for Medicaid patients. But I would like also to propose the revision of fee schedule for BFCs providers. Just recalling the number that JCPS health director has shared with us, that only 67 BFC providers actually provide. There are a lot more. I cannot recall at this moment the exact number of BFC providers in the whole Louisville area, but only 67 do provide vaccines for BFC kids. So, and one of the main propositions for this to happen is that the reimbursement for those providers is really low. In a case that the reimbursement for medical examination or the well check for a kid, it's better reimbursed, and that's been done, but not the vaccination. And this could explain the low vaccination rate that prevails in the JCPS population. So I would just add, if possible, just to check on that and see if it's up to date. And since we're gonna do a review of fee schedule, I would just propose that.
And you mentioned the number of VFC providers. So is your question like to look at the admin fees that VFC providers get? Is that what you're asking? Mm-hmm. Yeah. So the one of the challenges, and is the admin fee, is a set fee, and then we get the medicine for free. But the overall admin cost, there's no payment for that. So paying a nurse, part of a FTE for a nurse to run the program in the office, that's not reimbursable for it's not a paid thing. It's just a cost of doing VFC. So you just would like to have what the current admin fees are, and I think Judy knows those off the top of her head. But Judy, do you know the?
I do, sort of off the top of my head. I think it was $27 and like 46 cents is what you get for the first shot, and then you get, I think, $9.80 for a subsequent shot. So let me find where that's written somewhere. Yeah, $27.49 for the first shot, and then $9.80 for the second shot.
And this is the updated fee that this is the last one.
Yes, this is the current one. I'm not sure when it was updated.
Could you check on the date and just let us know whenever you get the chance?
Let's see.
Thank you very much. Okay.
Thank you.
So, do we have quorum yet?
No, we do not.
Okay, thanks. Okay, so the next 3 items on the agenda, 4 items, I'm not sure who wants to take which topic, so you all can just jump in.
Dr. Richardson, Danita and Angie are taking 1 and 4, if that's okay, and Leanne and I are doing 2 and 3 together, so you'll get 1 and 4 from Danita.
Okay, great.
It looks like the $9.80 was updated in 2018, and the $27.49 was 2022. I'm sorry, 2022.
Thank you.
Okay. This is Danita. I'm just going to do a quick update on the Racial Equity Action Plan goals. As far as the Racial Action Plan, with the racial action plan, we have goals that are both enterprise-wide as well as division-wide. And with the division goals, we have obtained the dates, the quarterly reporting dates that we will be reporting to Commissioner Lee. So those dates are available for the TAC members to participate in. So we can share those dates and those invitations with you. Those are going to be on Monday, March 27th, June 26th, and on February the 18th. Those first Monday dates are going to be from 3 to 3:45, and then when we move into December, that's going to be from 11 to 11:45. And those will be when we share those geared tool activities that all the divisions have uploaded their strategic goals, and they will be sharing the updates on their progress, what that progress looks like, and each team will provide a presentation, 5 to 7 minutes. They'll provide to the commissioner on what they specifically planned, where they are, and any barriers or challenges that they may have had. When we talk about the enterprise goals, as far as the goal that we set for the updated language for the MCO contracts, that was effective at the beginning of January. The RFP language, that was also effective at the beginning of this year as well. Also, I see that there was some plan for CMS drafted language for the new CMS waiver. And I think Deputy Commissioner Hoffman has updated on that previously. But as far as the racial action plan, those are the updates for that. I can move into the MIC. I do have some information on a timeline for a PowerPoint if I can share my screen.
Sure.
Kelly.
Give me just a second, Danita. I'll make you co-host.
And then Danita, if you can just give us after those quarterly dates come up, just at the following TAC, just kind of give us a high level of what was happened at those meetings.
Oh, they have not taken place yet. And so
just at the next, the next TAC after the next quarterly meeting.
Okay.
You are co-host now, Danita. You should be able to share.
Gotcha. Okay, can you see the screen? Okay. So just a quick reminder of what the MIC is, the Medicaid Innovation Collaborative. It's structured so that we can bring the state partners together so that we can come up with, an innovative way so that we can address the issues that some of our Medicaid teams are facing when it comes to addressing the needs of our Medicaid enrollees or participants. The first cohort involved behavioral health teams. With this specific cohort, we are addressing the social determinants of health. And in this cohort, it includes Iowa, Kentucky, Nevada, and New York. Our goal for these teams are that we want to identify and develop solutions to address the health disparities, for our members. And we're looking at quality improvement initiatives, service provision, payment structure, and specifically data technology. I have listed on this slide the link to the MIC page, and I can also drop that into the chat. But if you go to their website, there's a wealth of information about the MIC team, those partners, and some lessons learned from that first collaborative. So it shows you some interesting details on the work that they have done, how they came to where they are, and why we are interested in this initiative. where are we now with this, with the MIC work? What they first, their first steps that they done was that they sent out a survey to all the states that are involved, to some of the participants. They did a random selection, and they asked them some questions about social determinants of health, about their specific food needs. And then there were some general questions about some chronic conditions, and just got some information back on those surveys. At the beginning of January, we met with the MCOs to talk to them about the MIC collaborative, what our goals were for the MIC, and specifically ask them, what their goals were with equity and social determinants of health. They provided us with some PowerPoints on what they were doing. We talked to them about our goals and the equity and determinants of health branch in specific. We held the MIC kickoff where Kentucky provided to the MIC team what our goals were. We specifically identified those with the team to tell them, these are the things that we want from this MIC collaborative, which was for them to help us with those things that we listed on that first slide. What they've asked from us was that we provide to them 2 individuals from the MCOs that would be their contacts. Each of those MCO contacts have very distinct roles. One will be the champion and one will be the liaison. One sort of works within the MCO organization to sort of champion what the MIC goals are, to make sure that they are on board. And then the other role is going to be more involved with the MCO collaborative and participate more in the meetings and the actual things that we're going to be doing as we move along the way. We had a recent meeting with some other states where they gave us some information on some research that has been done with some other Medicaid participants, and some ideas about ways that they have met social needs, medical needs for some participants. Some ideas such as medically tailored meals and information such as that. All of this is information that we can provide to you all as well. When we receive these resources, we keep these internally as a sort of a resource repository for our teams to share. The next steps that we are going to be doing is that we're going to have a series of technical assistance meetings. Technical assistance is going to be with 2 representatives from our IT, since the technology piece is going to be important for us. So we've identified those 2 participants, and it's going to be a series of the IT needs along with our policies and procedures. Before those meetings get started, on Friday, we're going to have our research readout and requests from information feedback. That meeting is going to be recorded, and we are happy to share that meeting, the results from that meeting with you all, so that you will know firsthand. And the other piece that's important for this group is that Angie and I just had a meeting with the MIC team, and they would also like members from some of our stakeholders to be involved with this collaboration. So they're going to create an email to solicit that membership. So when we receive that communication, we will send that out. Not sure at this point how many members that they want, but when we have that email, we'll send that out so that we can have your voice included as we go through this innovation collaboration. The other thing that I think that's important to share with you, and it is on down on this agenda, is what the MCOs are doing. And I think that it fits in with this part on the agenda. So I talked to you about the meeting in January where the MCOs provided us what their strategies are as far as equity and social determinants of health. With the information that I'm sharing with you right now, it's not meant to say that this is all that they're doing, because it's hard to capture what they're doing in a PowerPoint. So, this is just a high level of some of the information that we captured. 4 categories that are important in the work that they do are, the interventions and referrals, and of course, those community partnerships, and the work that they're doing towards their organizational improvement. And what we all find important is the data capacity. Some of the highlights that.
Can you put your slides on slideshow so it makes it a little bit bigger?
Oh, it's not on slideshow. I am so sorry. Better?
It's okay. It was fine until last when it's hard to read the little.
I am sorry, Dr. Richardson. Are you seeing, which screen are you seeing?
Now seeing a big screen, then we have the next slide viewable as opposed to just the slide presentation.
There we go. Is that correct slide?
Oh, perfect. Thank you.
I apologize for that. Okay. So on the right, this is just where I captured some of the things that they shared in their PowerPoint presentations. And this is just not from one MCO, it's just capturing several of the things that they all shared. Just highlighting, their ability to capture some of the SDOH information on their dashboards, how they are using some inclusivity and diversity measures, their integration of the Kentucky Minority Health Report and things like that. Then I just broke this down a little bit by the MCOs. 2 of the 6 of our MCOs are already NCQA Health Equity accredited. So we felt like that is worth mentioning to this TAC. But the next few slides just kind of break down by the MCO, very high level, just a few of the things that they do. So just, with Aetna, this just mentions how they use the community health workers in their networking. And as far as their internal processes, how they have this health equity committee. With these, I don't want to use a lot of the time, since we've had quite a bit of time already on our first pieces of information. There is a table that was created, and I can share that with this TAC. I think that would probably be a better use of the time, and we can move on to the next part of the agenda.
Thank you. Thanks. That was great information, and we'll look forward to hearing more from the as things proceed. Any questions? Thank you. And then the GARE tool and the health equity infographic, any updates on that?
So 2 things, Dr. Richardson. The health equity infographic, just for sake of time, I can send that to you again. It's the same one we had before. We had just updated it after our last meeting. Based on some things that Danita has told you that we've recently done, we may want to update it just a tad more. We did update it for you, but then we had those kickoff meetings and things with our big MIC group. So I can go ahead and send that to you. But again, I think we might want it to be updated again. I think that was sometime in the middle of January that we last updated it. And then for the GARE tool, as you remember, we sent out just a sample GARE tool and I think a short video a couple of meetings ago. And I've asked Leanne Fitzpatrick to come and speak to you about the GARE tool and our mobile crisis initiative. I'm kind of using that as my first real going forth with the GARE tool, and how can we use it and what changes can we make from it, and looking through that lens. And so I've asked her, it won't look exactly like the document that we've sent you as an example, because she's actually put it in like a presentation for you. So it'll look a little bit different. Same questions, right? And I asked them, our team, to put in the things that we've changed in red so that you could see how fluid and what a living document that we've got going on. So Leanne, do you want to go ahead and start that? And one other thing, it's pretty lengthy. So if we, Dr. Richardson, if she gets along in the time and you want us just to send the rest of it out for questioning, that's fine too. So go ahead, Leanne.
Can you make me co-host so I can share, please?
You are Leanne.
Oh, there I am.
And thanks, Leanne. And if you, I don't know how much time would you like, or how much time do you need?
Well, just a bit, I don't know. Just tell me if I'm at time, because I could probably talk about this, for a long time. But are you seeing the slideshow? Okay.
Yeah. We're seeing the slides plus the preview. So if you want it from beginning, that might make
yeah. Danita, how did you do that to make it large? I'm sorry.
I selected swap view.
You selected what?
Swap view.
Got it. Thank you. So just a little background. I won't go into a lot of detail in the background because we can send this out and you'll be able to read a little bit more. But September 2021, we received an award from CMS for a mobile crisis planning grant. The grant was awarded to 20 states. We already have these services within our state plan, but we realized that we needed to do some research and kind of beef those up and better describe and define these services. One of the major accomplishments that we had is in a need assessment that's on our website for you to view. It's a lengthy 260-page document, but it really we had to look and see where we are as a state and where we are looking for those services and how we're already providing those services right now. So due to the needs assessment, what we did is that drove every decision, any conversation, any thoughts that we had is we went straight from our needs assessment and we did extensive community outreach for that, interviews, everything. So we have developed a comprehensive Kentucky model. We call it our mobile crisis intervention services that we hope that will come in place in October of 2023. Some other things that what we did is we have developed a Kentucky crisis co-responder model. It's a CCCR. Right now, what we are doing is we are talking with our community stakeholders. We have interviews set up, focus groups set up. We're reaching out to anyone and everyone that we can to help us build the best co-response model in the state. And that's us giving you a sneak preview. This is our future model.
Leanne, I'm not
yes.
seeing an advanced slide. Is that me or is everybody seeing Leanne advanced slides?
No, you're right. They're not
Advancing.
That's the first one.
So you're still on the first one?
Yes.
Well, what am I doing wrong?
Go to your lower right by the volume. There is like a screen. If you click in there, maybe.
Okay. Do you see it now?
No.
No. Now it's switched.
Okay, so you see the future MCI model?
Yes.
Okay, I sincerely apologize for my lack of technology skills. So this is our future model. As you know, that we have 988 centers that is in 12 of our CMHCs. Once it is determined that a mobile crisis dispatch needs to happen, this is where it's going to come in. we are working on the triage of what would constitute a mobile crisis dispatch. So this is our plan for the future. And right now we hope to have this implemented, like I said, in October. All right, so the GARE tool, you have a blank copy it's going to look totally different, like Leslie said about this. But what we did is the GARE tool seeks to eliminate racial inequalities and advance equity. One thing that I have noticed when we went through this, and this is the second time I have gone through the GARE tool with a certain initiative, but it really makes you think. Are you really thinking of every corner and every type of person and every community with this initiative? Are we addressing every community, you know, with this? Or are you looking at, oh, I didn't think about that. Oh, and it really does make you think. When I first looked at this, and I thought, well, yeah, we're doing everything right. We are considering everything. But once you got into the tool, you're like, oh, no, we're not. So it was a very good learning tool. This right here, what we're going to show you is a living working document. We update this, and we've updated it, we created it and then updated it once. And then we'll go back to this as well. Because of the GARE tool, our communication plan has really changed and has really grown in the different ways and the different populations that we're going to reach out to people. So I think our communication plan has definitely grown a lot larger than we thought it was going to. But we have the 6 steps for the GARE tool. And we'll go with the first step. Determine proposal result and desired outcomes. So as you can see, there's a lot of red, which is a good thing because we're learning. The first, and what's in black, like here, is what we had in our first responses. And in our second, you know, after we reviewed it again, we realized, wow, we've got to realize that there's no wrong door, no person, regardless of any type of gender, equity, income, social status, where they're from. All Kentuckians can benefit from this service. We really talked about data. And we need to realize that the data needs to drive our outcomes and drive what we do to update our plan and our program. The second question is, what does the data tell us? Now that we know, we decided, okay, we need these data points, we need this part, what's it going to do for us? It isn't, we did originally, yes, it is, it's going to be statewide. But we realized neighborhoods, cities, regions across the Commonwealth, we need to look about service delivery in those areas. The initiative takes into consideration race, socioeconomic, demographic factors on a local level to ensure the unique characteristics in one of the communities that we need to meet. Yeah, we said, yes, we're doing it. Now we got to think about, okay, we said we're doing it, but how are we doing it? And this needs to be a more in-depth answer. According to the U.S. Census, the breakdown of racial demographics in Kentucky is 8.6% Black or African American, 1.7% Asian, 2.2% of 2 or more races, 4.2% Hispanic or Latino. While Black or African American individuals represent nearly 9% of Kentucky's population, we looked at which counties had the highest population. Jefferson at 55, Christian 54, and Fayette at 52. And with the question of what does the data tell us, is there any data about existing racial inequalities? Do you know that might be driving these, and what's driving these inequalities? And yeah, we know there's inequalities, but what are they? How is the data going to help us address those inequalities and assist those people of Kentucky? As you can see, we had barely any type of answers to the question the first time around, and the second time around, wow, we really thought about it. Why aren't all the other communities besides the white community not seeking services? Mistrust and fear of treatment, we learned. Perceived discrimination in the healthcare system. Maybe a family member or a friend was treated a certain way and they don't want to be treated that way. Cultural stigma, lack of evidence-based practices in mental health treatment, due to limited diversity in medical research. Barriers related to social determinants of health, like transportation. I know we talked about transportation earlier in this meeting. When we did the needs assessment, that was the one thing that really came out was transportation. That these people might need the services, but they cannot get to the locations to get those services. And with, of course, with the pandemic, how that's opened up things and how we are seeing telehealth as well. There is a shortage of behavioral health providers for the diverse communities. And I don't believe that is Medicaid can answer that question or solve that problem. I know of course, I graduated from UK with my master's in social work, and I know the social work program is really bringing on diversity incentives and initiatives to bring on those people to the College of Social Work. But how, the question is, and how do we bring those providers to Medicaid? Where do we get those providers? That's the question. In a lot of meetings with other states, I ask those questions. How do you get those minority providers to be a provider? You go in that direction because you don't want to go into mental health or behavioral health for the money, because that's not it. You go in for other reasons. It's in your heart, and you know, so it's hard to determine who of those. Sorry, the wind got me. Yes, like I said.
I think that might be just, I was going to say that this might be a time to break, because we can always pick this up at other meeting. I don't want to rush through it because this is amazing content. And so I'm wondering, would that make sense to kind of hold here and then keep it on the agenda for next time and to talk, so we have some time to talk about it more, because it's such great information.
Mm-hmm. Okay.
I'm just, especially that last slide was just like, you hit like so much fundamental.
Yeah, I've only gotten through half of the presentation, so.
Yeah, so I don't know. I guess it wouldn't make sense to send it out so we can read beforehand, but unless you all think that would make sense, but we'll keep it on the agenda for next time maybe. And so kind of recap and then start at that next slide.
That's fine. We can just finish the second half of the presentation and then we'll send it out to you. How about that?
Okay, that sounds great. Yeah, I want people to be able to have time to ask questions and everything too.
Yeah, we kind of, because this was going on at kind of the same time that our GARE tool was coming about to complete, to complete one of those as a sample. We just really wanted to use mobile, since we're trying to meet the need of the entire Kentucky population with this, even the uninsured. So we thought this would be a good model to start using towards the GARE tool. And when I speak of that, it's the behavioral health group within Medicaid. Every other division has also got their own priorities going on and GARE tool initiatives. So we've got lots going on in Medicaid right now, and the other departments that lead up to the cabinet.
That's great. And then after we have a chance to hear the rest of this one, then we'd love to continue to hear as other GARE tools are being implemented. I think that's great information for us to be able to hear and then give feedback on. Just looking at the rest of the agenda, I know Vivian, we reviewed the minority health report, or we received it, but we haven't really, oh yes, we did talk about it, I think a little bit. And oh no, we didn't talk about it. We talked about community conversation ideas last time. So I listed all those community conversation ideas. And I think they were community conversations that might be planned by DPH. But I don't know if Vivian is on the call today, or we can hold that as well to a future meeting. I don't hear Vivian. The next section is a recap of the Division of Quality and Population Health with just follow up from the last meeting. So I don't know if we have anybody to give that update.
Angie, are you still on?
I'm sorry, what was the question regarding population health?
It's E on our agenda.
It
Which
was
I
just
don't,
things to follow up from the last meeting.
I don't remember.
So,
yeah.
so one thing was on, we've talked a lot about demographic data, race and ethnicity
Oh.
data, and how can we know that it's limited, but how are you using it? How can we help you use it and look at that to be able to advance the equity conversations?
Well, I mean, when we're looking at all of our reports, we are looking at how we can address that.
And then maybe the question then is, what reports can you all bring to us to share with us so that we understand some of the issues around disparities and equity?
I'll have to do some more work on that. And maybe by the next time I can have something that I can share.
Great. And then in the last meeting, there was something called the Health Disparities Initiatives that we were going to learn more about. Do you know what that was in reference to?
So this is Danita. That was the Medicaid Innovation Collaborative that I just provided the update on.
Okay. Is there anything else under the Health Disparities Initiatives?
No, that is it.
Great. And then any other updates from the Equity and Determinants of Health branch manager?
Nope, that is it.
Okay. And so in organizing this agenda, it was hard for me to know where to put the categories. So the Racial Equity Core Team, what do you all cover versus the Equity and Determinants of Health branch? Where does the Racial Equity Core Team fall?
We have a core team for Medicaid, which if you remember, Jody Allen and I kind of started that. This was prior to us having a population health division under Angie, or even having Danita come on board as our branch manager. So I've been staying involved kind of as Medicaid's champion, but the population health group is kind of starting to take over and take the lead on the racial and health equity. Does that help? I'm sorry.
Yes, yes.
It's confusing because we were so lucky. We got the support to actually develop that division and that branch. We were very lucky to do that in the midst of us trying to make change. So that was a very positive.
No, that's great. So we can in future agendas include the Racial Equity Action Plan and all of the things under Equity Core Team under that thing.
Yeah, because we all met together today and decided who was going to do what. So it's fine.
That's great. Okay. All right, so we are to new business. Or is there any other old business? I'm sorry.
The only thing I had, Dr. Richardson, sorry, am I on mute? No, okay. I did have Aaron to send me a report on the CHFS listens. That's your F that was on that agenda. And it's not horrible. It was 135 reported CHFS calls or emails. For me looking at this report, it's a very simplistic report. There was 35 related to service inquiry. This is not racial and health equity specific. 24 to member services. Member services inquiry was 10 and 5 to billing. So that was 75 that I just gave you out of 125. So nothing really that stood out to us related to specific to racial and health equity, if that makes sense.
Yeah. And it's hard, especially after that last slide that was covered with the GARE tool. Sometimes it's hard to tease out. Some of those things may be related to racial and health equity. Yeah. So I guess it could be. But at this point, I guess it's hard to know. Thank you. Anything else under the old business or updates? And do we have a quorum yet?
Okay.
No, I'm sorry, Dr. Richardson, there is.
During the last meeting, we discussed the issue of access to bilingual services, and
Yes.
and we wanted to look at the trainings that are available to become health interpreters, certified court and health interpreters. So I would like to know if there's any follow-up in increasing those opportunities across the state, even though that we see a higher concentration of English language learners in some areas of the state. But we provide services in Western Kentucky, and we have seen an increase in the number of Burmese families and Spanish-speaking families that have moved in the area, and we would like to expand the capacity to provide services, but we do need more interpreters. It's been very difficult to get certified interpreters, and maybe this is an area that we can help move the needle, for the lack of a better word, in increasing capacity for those training, and therefore increasing access to treatment.
Great, thank you. So any, where can we assist Medicaid in moving forward with something like that?
I don't have anything specific to answer for you. We do what we call LEP interpreters, which have to be certified in the cabinet, but I don't know what to tell you right now about providers. I'm guessing the MCOs all provide interpreters if needed. I don't have any answers for that one. If anybody else on Medicaid's team has an answer.
So I think maybe there are two questions. One is, how can we get more people trained? Is there any capacity within Medicaid to create that opportunity? Was that one of your questions, Wanda?
Yes, and also the issue of reimbursement, having MCOs paying for translations and for the time spent, if we have staff doing that as part of additional duties. I think it will help tremendously to attract more people from the community if we know that we will be able to get reimbursed for those translations.
Great. So maybe those can be under follow up for next time. So is there capacity within Medicaid? How can we get more people interpreted with Medicaid's kind of support financially, with creating opportunities? And the other is, and as you know, Leslie, not all the MCO, we can't get interpreters paid for the most part with the MCOs. There's some access, but it's not where we want to be as a state. I'm sure as far as ease of access and knowledge of how to access and all of that. So we had skipped those under the old business, so those can be
back on.
I think that should be an expectation in their contract, that they pay for those services, because that's the only way that you can provide access to healthcare for those individuals.
Right, and we're required, we're required by law to have interpreters, but it's a very expensive and often unpaid, very expensive and unpaid. But we can't function without them, so you have to have them. Yes, extremely important. And also in that same category, there was a comment about when Dr. Straub was involved, and there was an immigrant health work group, and somebody was going to try to dig up some minutes to see what the recommendations were, because that sounded like a really good community forum process. So
Dr. Richardson, I did follow up on this one. Unfortunately, we've lost Dr. Straub, or Commissioner Straub. She's no longer with us, and Hopefully she's retiring on a beach somewhere. Probably not. I did reach out to the acting deputy commissioner, or no, not deputy. She's the acting commissioner, Lisa Dennis. She said that she thought that that was something that previous Commissioner Straub had worked on in her consulting world. So she's going to reach out to her. They still are in contact, and she's going to reach out and see if I tried to get her to come to the meeting today, but of course it wasn't on her calendar, so she didn't know to come. So yeah, she's going to reach out, and her name is Lisa Dennis, and she'll reach out and see if she can get some information related to the immigrant health worker report.
Fantastic. Great. Okay, so we have about 6 minutes. Anything else under old business? I just put under new business. I think it would help the TAC to understand the Medicaid organizational chart and all of that. So maybe just a 30 seconds at the next meeting, just kind of outlining that, kind of how Medicaid falls, so that we understand when we're advocating or talking about issues, so we know who all the players are. We have a.
Sorry, I was on mute. Did you say? I'm sorry. So you want a Medicaid, like our organizational chart?
Yeah.
But do you want it? Would it be helpful for you to see from like cabinet down? I think we've got that.
I think so. Yeah, whatever you think would be helpful to help us.
Well, it's hard. It's hard to understand if you don't work in it every day.
I know. I was on the website. I was like, I'm not sure what I'm looking at.
Yeah, I think we have one. I think so. You have all these, the governor, and then you have all the cabinets, and then all the cabinets have secretaries, and then it starts coming down. So we're the department under our secretary.
Mm-hmm.
Yeah, I'll see what I can get for you.
So just real quick, it sounds like we don't have any recommendations to the MAC this time. Dr. Batista, were you able to attend the MAC meeting, or do you have the next one on? Do you want to give us any updates on that?
I attended the MAC meeting. They talk about the high mortality, morbidity on maternal, special racial groups being affected, and the changes that Medicaid has been doing, the follow-up for a year instead of just the first 90 days. So that's a really good thing. And also Dr. Schuster mentioned, and she talked a lot about the short staffing that the whole state, the Commonwealth is suffering. And she proposed some things to help, retain people that is becoming health providers, particularly physicians, but everybody else, nurses and mental health specialists, because the shortage, it's affecting everybody.
Thank you. And then we have general discussion left and volunteer for chair, and then our next TAC is listed there, May 3rd from 1 to 3. So any general discussion or volunteers to be the chair for the next 2 meetings?
You're doing a fantastic job. And you want to continue it?
No, that's fine. I did mine.
Yeah.
No, I resign. So Wanda, does that mean you'll do it?
Not this time, next time.
Okay, who wants to do it next? Jordan.
Would Dr. Batista like to go from co-chair to chair?
I cannot do that. I need a lot more experience. So I would like to witness you, Dr. Jordan, and then maybe next time after you.
Yeah, I'm trying to learn from Dr. Richardson myself. So
was that a yes, Jordan?
I can give it a try. I feel like I'm fairly high functioning and attentive, so I can give it a go. But
well, it's nice because the minutes are all transcribed, so just that's where all the content comes from. So
that's right.
Yeah. Fantastic. Okay, and we are at 2:59. Any other business?
New business. One issue that I would like to for us to consider is a discussion about the juvenile justice system and access to behavioral health treatment and support, healthcare in general for minority youth. They are overrepresented in the juvenile justice system, and there are so many issues and bill. There is a current bill, HB3, with sweeping changes to our juvenile justice system. But as much as this is a safety issue, it is essentially a health issue as well. And I wonder if this will be a good area for us to consider exploring what are the barriers to effective care, what can we do about it, if there are any statistics that can point to what our health system needs are in order to address the problems that we're having. So just want to put it out there. There is
I can give you a short amount of information. This is not necessarily specific to racial and health equity, but it's all juveniles. There's two bills out there. One for us to provide services or Medicaid to children that are in confinement or institutional type of settings. And then there's one that's a little bit less, like maybe just for substance use services. I'll have to take a look at that. If you all have heard me speak before, we've got an incarceration amendment setting at CMS that we're hoping will be approved soon, and that is to provide substance use services to people that are incarcerated. But right after we submitted that, we immediately started working with the DJJ, Juvenile Justice System, to see what we could do on the confinement side. But we did slow down because CMS hung the incarceration amendment up for quite some time. But I do want to let you know that we are looking at, in general, trying to take a look at juvenile justice and what Medicaid can do to try to help that department with those members that are in confinement. So we've got a couple of things. We've got a mental health institute in Louisville that's coming up. That's one of the focuses. That's not until May. I just wanted to tell you that if you're interested in it. There's an omnibus act that's out there right now in the federal world that says that the federal government wants us to cover juvenile justice and confinement by 2025, I believe. But we're going ahead and taking a look at that now. As well as we've got an MST pilot that's going on right now. We're Medicaid partnered with all of our sister agencies to provide a multi-systemic therapy 3-year pilot. I've got 3 providers in the 3-year pilot. We are having an independent evaluator to take a look at it and see if we can sustain it. But it's children that are in Medicaid from age 10 to 17, and it is an intensive therapy to provide to the child to keep them out of any type of juvenile justice system and to keep their placements within home. So we've got tons of things going on right now. Could I address one specific area right now? No, but just wanted to let you know that there are many bills and federal initiatives that are driving what we started about 2 years ago, but slowed down because CMS was unable to move forward on any approvals to cover those services at that time. But I've just recently met with CMS, and I'll quit talking here in just a second. We've recently met with CMS and 12 other states that have those same similar types of amendments in with them. They have over 50 1115s to get through, and they have 12 that are specific to incarceration. I believe we're first in line. So they didn't tell me that on the call the other day, but I'm pretty sure that we were the first that submitted that amendment. So I can tell you more very, very soon. I've asked for a one-off with CMS to talk specific to Kentucky, but want to make those changes. I just want you to know that's something we want to do.
Great.
Thank you for that.
Okay, is there a motion to adjourn?
Motion.
Any opposed? Well, adjourn by acclamation. Thank you all so much for the
Thank you.
conversations.
Thank you.
Okay, bye.
Thank you all.
Thank you.